All right, I'm going to move this toward me. I'll let our panelists know, since you missed the tutorial at the beginning, which is totally fine. With these microphones, you'll want to press the on button before you talk, or else no one will be able to hear you. We've got about 20 to 25 people watching us online, and then our beautiful audience here. Before we get started with our next panel, we're going to do another drawing. This one's from TCA, so again, my super official way to do that. And it's going to be Kim Smith from Second Stride will get a TCA prize, so congratulations, Kim. And TCA will send that to you in the mail. Bev's here. Bev, if you want to take a seat with your two other panelists on that side, that would be perfect. All right, and so our third panel today is called Comeback Kids, Best Practices for Rehabbing and Marketing Horses Retired Due to Injury. I know everyone in here deals with this in some form or function, whether it's on the rehabilitation side, taking these horses in from the track and rehabbing them, or in Stuart's case, dealing with them on the track, or marketing them for adoption to the public. And there's two sets of challenges that come with that, probably more than two sets, but we're going to deal with the two sets today with rehabilitating them and marketing them. So we've got Ashley Watts from CANTER Kentucky. We've got Lori, who is from Friends of Ferdinand. We've got Bev over here from MidAtlantic Horse Rescue, and Dr. Stuart Brown from Keeneland. And what I'm going to do, because I know when I introduce myself to an audience, I probably know what I want to say better than the other people introducing me. So I'm going to ask each of you guys if you wouldn't mind giving a 1 to 2 minute overview of your background, both with your nonprofit and your general equestrian background. That would be really helpful for the lead into this panel. So if you wouldn't mind going first and just turn on your microphone with the button. No, it's on.
Okay, hi, I'm Ashley Watts, and I am the trainer for CANTER Kentucky, where we retrain horses after their racing career and help them get adopted into new jobs. I also have a business where we do hunters and jumpers and lessons and sale horses and show locally, and I also have a bunch of small little animals that we rescue as well.
All right, Lori.
All right, thank you. I'm Lori Miller. I've been working with Friends of Ferdinand for probably 10 years, maybe a little bit longer, as their head English trainer. We just started with a Western trainer, I don't know, 4 or 5 years ago. And on top of that, I have my own business where we board and give lessons, and I have sale horses, and I primarily focus on eventing.
Hey, I'm Bev Strauss from MidAtlantic Horse Rescue. I grew up a totally horse-addicted kid. We did pony club. I always loved racing, though. So I evented and fox hunted and played polo and all that. We ended up going to the racetrack in the, I guess it was mid-'80s, early to mid-'80s. We had a small string then, and then we actually got to a point where we were seeing what was happening to racehorses after they were done running. We were based at Delaware Park. So a good friend of mine and I started MidAtlantic Horse Rescue, and I actually stepped away from the racetrack for a while, but now we're back. We've got a small string again. Our kids grew up and they're off on their own, so my husband and I got back into racing. But we've grown MidAtlantic Horse Rescue. We started out pulling horses from kill pens and feedlots, and now we do a lot of transitioning right from the racetrack.
Good afternoon, and I'm Dr. Stuart Brown. I'm the Vice President of Equine Safety at Keeneland Racecourse here in Lexington. I was foaled and raised in Versailles, Kentucky, a short drive from here. I did not get very far in life. I've had a career growing up as a product of the Central Kentucky horse industry here, where I've been working since I was about 13 years old, and I was fortunate enough to be mentored by two of my great professional colleagues, Dr. Dave Parrish and Dr. Dave Fishback at Haggard, where after I went to veterinary school at Tuskegee University School of Veterinary Medicine, I came home as an intern at Haggard's and had a career there for 30 years. And then about 1.5 years ago, I was recruited into a new position by a good friend and colleague that I had at Keeneland that was the CEO at the time, Bill Thomason. who I had worked with for 25 years at Mill Ridge Farm. And Bill had this concept of forming an equine safety director over sales and racing at Keeneland. And he and I had worked professionally while I was on the Racing Commission here in Kentucky as the chair of its Equine Drug Research Council, and also while I served on the Racing Committee of the American Association of Equine Practitioners for a number of years outside of my professional career as a private practitioner, where I saw a lot of horses that came back to my clientele here in Lexington in the central Kentucky area, who had been products of the industry here, as you work on the factory floor here and producing a lot of foals, and then see a lot of horses would come back here that I took care of a lot of stallions here, a lot of mares, a lot of yearlings, but then saw a lot of fillies that would come home from race careers, as well as a lot of colts and geldings, and sort of had this opportunity to look at a prism through that, mirror or that lens a little bit at those horses at the end of their careers, and to help a lot of my clients and in advocating for them. And then along the way, had this opportunity at Keeneland, which has been extremely impactful, especially in the Kentucky horse racing jurisdiction, where along with our partner at Churchill Downs, we've really worked to advocate for a lot of new safety initiatives to hopefully protect a lot of thoroughbred horses beyond their flat racing careers. It leads to an area that I'm very passionate about in this space of aftercare. And I've been fortunate enough to have a breeding farm that I share with a counterpart I have over here on the right, where we raise a lot of thoroughbred horses together, and really spend a lot of time certainly following and being a part of their careers beyond the operation that we have in Versailles or in Woodford County. And so it's kind of a walk the walk moment, but I really, really enjoy the opportunity we have to see thoroughbreds that compete in flat racing, that return to have careers beyond their flat racing careers. And it is of no surprise that these horses have such incredible versatility when you witness the kinds of things that they're capable of doing in their racing careers, and think about their adaptability to all these different disciplines that are on display here in the Thoroughbred Makeover, that remind us of how really unique they are across the breeds of horses that are out there. And it should be no surprise to us that they have this incredible versatility. So I thank you all for inviting me to be here today.
Thank you, all four of you. I guess let's start, Stuart, since you're the medical professional on the panel. Can you give kind of the overview of bone injuries or osteo injuries versus the soft tissue, and kind of introduce us into what we're going to be talking about?
Yeah, I think in a lot of respects, when people talk to me or discuss with me about horses that they're looking at, opportunities that they might have beyond their racing careers, one of the things I start to think about relative to those horses, especially if they're ones that are going to need to be rehabilitated, or they've got potential injuries or whatnot, is, are we talking about soft tissue injuries, or are we talking about orthopedic injuries or bone-related injuries? And if you start to think about both of those scenarios, and then think about the age of the horse. So for instance, if somebody's talking to me about a lame horse that they're looking at a potential second career for, and they talk to me about a horse that's a 3-year-old or even a 2-year-old later on in this year, one of the rate limiting steps all the times for horses in that stage of their career in thoroughbred racing is going to be their knees. So asking questions about potentials for knee chips or potential slab fractures or even just arthritic changes in the knees is something to sort of keep in mind, because how you approach those in terms of what the needs are of that horse for potentially entering into other careers is different than the horse that's 7 or 8 years old that may be retiring after a longer career that they may have had, and whether or not those horses might have soft tissue injuries relative to bowed tendons, suspensory injuries, desmitises, and those kinds of things that require a whole different set of approaches relative to the time given or the potential therapeutic options that we have. So in the former case, it may be that it's an orthopedic injury and then it requires a surgical intervention, whereas the other one may require time. It may require other, therapeutic approaches that we have relative to PRP or stem cell or IRAP. And I bring those concepts up, which might have been a little bit foreign to this conversation 7 or 8 years ago, but we just finished a 4,000 horse September yearling sale here at Keeneland, where we had a buyback rate at most of the sale of less than 5% at the end of it. And we had the lowest price paid for a yearling this year at the Keeneland September sale was $3,000. There were no bids, and there were only 37 horses for $10,000 or less. So think about that in the context of where it's moved the value of horses, you know, in terms of this discussion. And so when you think about those horses being worth more, and then potentially the marketplace that's been created for horses in this arena, then you start thinking about the investment of those kinds of therapeutic modalities that help horses rehabilitate towards second careers. And those investments may now be more justified. And so I think to me, it becomes important to separate out what is it that I'm talking about when I'm looking at that horse, and what are the things that are presented to me, and then thinking about where they are in their careers, how many starts have they had, what kind of racing have they done? Have they been dirt horses or turf horses or synthetic horses? And where have they run? And how many trainers' hands have they passed through? Because one of the things that we're certainly doing now that's becoming much more the norm than the exception is these filters that we now have for every horse that enters a race in Kentucky or has a speed workout is required to have an examination prior to those speed works or performances. And so we begin to look more critically through the lens of that horse's suitability for racing and training than we ever have before. And it's paying off that investment in those horses beyond their racing careers.
Thank you. I guess, so we had asked several of our aftercare organizations, what are some of the more common injuries that they see and they deal with, and they end up having to repurpose after rehabilitation to the public. And one of the ones that came back across the board was sesamoid injuries. So can you, Stuart, give us kind of the overview of what that injury actually is and kind of the scope that you can be dealing with there, and what the initial like care and rehab, if that happens at the track, would be likely, but not always, prior to when it would go to an aftercare organization?
So obviously the sesamoids themselves act as, you know, a part of the suspensory apparatus of the horse. So those two bones that fit tightly behind the cannon bone, you know, form articulating structures for the suspensory ligaments and all of that supporting structure for the fetlock joint, or for the ankle, as we typically refer to, that are so critically important. And they also become one of those really serious areas of focus for us relative to potential injury that can be career threatening. And so sesamoid fractures come in four basic types. We have apical sesamoid fractures, we have mid-sesamoidian sesamoid fractures, we have abaxial ones, and then we also have axial ones. And so differentiating the position of those fractures also has a lot to do with what the prognosis for those horses are. The apical sesamoid fractures at the top many times will heal on their own and also lend themselves really well to interventional surgeries, often arthroscopic surgeries that can be very successful. The mid-sesamoidian ones, though, represent ones that are a greater degree of failure of that bone to support a horse, you know, relative to an injury occurrence. And they're not necessarily always career threatening, but they also require a significant amount of commitment and time for rehabilitation. The abaxial ones, a lot of times, are the ones that happen that involve the distal sesamoidian ligaments. So they don't lend themselves very well to intervention a lot of the time. So we are very limited in terms of surgical approaches to those. However, some of those actually will heal with time. And keep in mind, some of the formulation of management that we talk about in terms of giving them time may be related to stall rest. It may also be controlled exercise when they come back from injuries that they have related to those. And then the axial sesamoid fractures are the ones that we see a lot of times that are along the midline, where we have the sheets of tissues that pull both sesamoids together to hold them tightly. And we see a lot of those occur when we have condylar fractures in the horse. So when we wind up with a condylar fracture of the cannon bone, because we've lost the support of that very important structure, the pull that exists, you know, laterally on those sesamoids causes there to be tension on the axial surface, and it actually pulls them away, and oftentimes in very long fractures. And so they may be very narrow, but they're often very, very hard for us to get to, and they're very, very hard for us to get stability so that they get actual functional healing. Most of these kinds of injuries, though, will heal given time. It's just the nature of the consistency of the healing and the strength that is returned. Because most of what we get back is a lot of fibrous connective tissue healing at first. And then one of the problems or challenges that the horse has versus almost all the other domestic species is from their carpus or knee and hock down, it's almost all blood vessels, nerves, and ligament structure. They don't have a lot of collateral circulation. And so a lot of times, in order to stabilize any kind of incongruency or any kind of motion that can occur that's instability, they lay down bone for that. And so we want to position ourselves to where we can intervene as best we can to support the horse healing in the most optimal manner, that we minimize excessive amounts of bone development there in those sites, because they'll lead to arthritic changes that can then limit the horse's ability to return to other forms of function. So in a nutshell, those are kind of the various forms of sesamoid fractures. And when you hear those terms and you discuss those with your veterinarian, forming the context of those conversations around what your expectations are have a lot to do with what the trajectory of your plan will be.
And so I'll then throw this to the panel. Can you guys, and you can kind of do it in a collaborative or conversational manner if you want, but can you talk us through kind of when those types of horses with these sesamoid issues come into your care, what kind of work do you do with your veterinarian and rehab wise to get them to the point where you can start getting them back into work? How does that process go?
Thank you. Whatever our vets recommend, we do. Sometimes they go to surgery, frequently at Purdue. And we just follow whatever protocol they've told us to do to rehab it, and we take a long time. And we will have those horses in rehab, sometimes a year, and then slowly start putting them into work. And I think typically most of them stay in flat work careers, but that's obviously up to what the vets tell us as they're healing, and we monitor all that with radiographs and whatever ultrasounds that they want have done, and maintain their feet and make sure that our farriers are on board to keep them comfortable. And it just takes a lot of time.
Bev, do you have anything to add to that? I saw you kind of go for your mic as well.
Yeah, no, I think time. And again, we look at the type of fracture. We'll get the initial assessment from the vet at the track or our own vet. We usually give them a year. And then depending on where the fracture is located, we'll either place them as flat horse only, occasional cross rails, but I know some that are going and doing jumpers. And again, I always sort of cross my fingers. We do take follow-up x-rays before we place the horse, just to sort of make sure we're all on the same page. It's always a little scary to me. I know when we first started the rescue, sesamoid fracture to me is like, oh, it was just a horrible thing. But we have so many of them now that it's sort of, it is what it is. I think the problem that we have is if we have an old war horse with a sesamoid fracture that's on the hot side, he's never going to be quiet enough to be that older person's trail horse. So to me, the risk of injury of those horses is great. So typically those are the ones that we end up calling pasture pets, because I don't think I can safely place them with somebody who's going to just go piddle around the trails, because the horse won't do that. But if you get another horse that's really laid back, we say, oh, it's a real confidence builder, and they can last for a long time with these old injuries. Their ankles might look ugly, but they really can do well. And sort of as a little aside, we bought a weanling filly in 2017, and I didn't look at the x-rays ahead of time, but 3 out of 4 legs had terrible sesamoid fractures. I showed them to 3 different vets, and I had 2 vets say, put her down, she'll never be sound. I had one who said, just wait and see. And she's been running. She's totally sound. Her legs are always cold after she runs. We don't do her up. We don't do any meds. So, there's a case, 3 out of 4 sesamoid fractures, and, she's proving everybody wrong. So anyway, I think it's back to go by the horse as well.
Mm-hmm. What about you, Ashley?
A little bit of what you guys are saying. It's just time, and each individual horse will kind of determine the treatment they need, because some of them will be well behaved and do the stall rest and work on the little paddock and the hand walking or walker, and other ones you're tranking them just to take them out of the stall or to keep them safe in the stall and not re-injuring themselves. So the main thing is the time and being able to have the space to keep the horse safe and be able to have the process they need to go through to rehabbing and be able to get back to work. But it's time. We have to be patient.
And you know, Bev reminded me of something that I think is worth us always keeping in mind too when we talk about sesamoid fractures. So keep in mind that in the forelegs, it's the medial sesamoid that's going to bear the majority of the load, you know. So if you find a sesamoid fracture in the front ankles and it's a lateral one, your prognosis really moves up considerably, okay, because their capacity to heal those effectively is always going to be a little bit greater than the medial ones, in spite of all the different scenarios I've presented to you in terms of position. And in the back ankles, it's the opposite. It's the lateral sesamoid that bears the majority of load. So if you find medial sesamoid fractures behind, they tend to carry a better prognosis than lateral sesamoid fractures behind. So, you know, in the case that you're presenting where it's 3 out of the 4 in the front, you know, and there's you know, they'll always make you look really silly when you're trying to make these kind of prognoses. That's why I'm not a fan of people passing and failing horses on exams, because, you know, there'll always be exceptions to that, and there's always a very humbling thing to try to look into your crystal ball, because a lot of them will overcome a lot of things that we won't give them credit for. But I think keeping those kind of general thoughts in mind relative to the prognoses you have kind of also helps you to qualify what the potential, you know, course of their healing will be.
All right, another injury that a lot of our aftercare partners have brought up were chips, and how there's what?
Actually, if I can intervene with a question, Dr. Brown. So when you're adopting out horses with injuries, do you have any recommendations for doctors that could be a therapeutic value to kind of extend the career or improve the horse's long-term usefulness?
I guess I didn't quite understand. Do I have a recommendation relative to?
So for the injuries that we're talking about, sesamoids right now, but for the nonprofits that are adopting out these horses, do you have therapeutic recommendations that could improve the longevity of the horse or improve a long-term usefulness and overall just provide a better career?
Well, you know, probably some of my panelists probably have better opinions relative to their experiences along those lines, but I don't think there's a one-size-fits-all. And I think that becomes a little bit about what the potential new owner's expectation will be relative to use, and whether that's the appropriate fit for the nature of the injury for that individual horse. To back to Bev's point a little bit relative to the fit for even the behavior of a horse relative to a certain injury for its use, you know, I think you also get into qualifying a lot of these horses relative to their conformation. So a horse that's badly back at the knee, that has a soft tissue injury, that has a weak forelimb or hind limb conformation, or a horse that behind has really bad curbs but's really sickle hocked and you know, horse stands way back out behind itself, that you're looking at a potential jumper career, that probably is not the right fit, you know. And so it's hard to have a one size fits all recommendation for those kinds of injuries. Sometimes it has to do with the horse and its conformational predispositions relative to the intended use.
And for the aftercare partners up here, can you talk a little bit or discuss between you guys, and I'm sure people in the audience have input on this as well, when you're marketing these horses to the public, what is your approach to marketing them to the public? Because I would think that you wouldn't want to put too much information out and have people making incorrect assumptions, but you don't also want to be hiding any limitations that horse may have. So what are some of the approaches you take when you're marketing a horse that's limited with an injury like this?
You're talking about once it's
Rehabbed or at the point that you are comfortable.
comfortable.
Mm-hmm.
It's so tricky. Like, the public is so tricky, and now there's so much on social media. You have to be really careful, or else you might the stigma will stick with that horse because it's out there. So usually we'll say like limited, trail horse or lower leveled flat work or something to that effect. You have to be very careful how you word it because that can just make everybody not want to even ask. Or it's really interesting to me when someone wants just a pleasure trail horse, but then they find out there's some sort of ailment, but it shouldn't affect their ability. They pass on it. Even though they rode it, it went really well. The horse is a great disposition to be the perfect horse for them, just because it has an underlying, it's really difficult to adopt out these horses with any pre-existing anything. It's kind of very frustrating, honestly.
I think the one thing, though, that we have as advantages as aftercare organizations is we stand behind our horses. So I don't care if you come back to me next year or 10 years from now or next week, we will take that horse back. So I think that that gives people a sense of security. And, no, we don't want these horses back. I mean, we really hope that they live forever in their homes, that people love them, but we have to stand behind them. So I think that when we say, well, this horse is limited because he's got this, that, or the other thing, but we're always here for you. We can answer questions. We can, help you through issues. We can take the horse back, whatever, we always say for any reason or at any time. So I think as a legitimate aftercare organization, that really, really helps. When people go to the track and buy directly from trainers and they don't always get the right information because he forgot to mention the horse has whatever, that's when we get the call saying, oh, I got this horse from so-and-so at the track, it's lame, will you take it back? And I have to say, well, we don't rescue people, we rescue horses. And if you had come to us, if it was our horse, no problem. Otherwise, we'll try to help you network. So, but I think that our strength is we do stand behind them. So it's easier to be very upfront. And I've gotten to the point where I just say, this is what it is. This is what we recommend. If you don't like it,
I usually tell them I'll get whatever records we have from our vet and send it to their vet so their vet and them can have that discussion versus giving them, it's just, here's what it is, decide if you can live with it.
And I would say the other thing that we try to do is have the horse already doing the job that they want it to do. If we're out trail ride, if they want a horse to trail ride, he's been on a 5-mile trail ride, 10-mile trail ride with this kind of terrain, and he's done that 4 times a week, whatever, so that they can put some faith in that the horse has been doing that job and he's stayed sound.
Another injury I wanted to touch on when we're still under the orthopedic injuries are bone chips, because I know that can be a wide range of things, but it can scare some potential adopters off who don't understand the differences. So Stuart, can you give us kind of an overview of the different types of bone chips that people will typically deal with?
Yeah, and I think that winds up being sort of a pretty wide cascade. You hear people talk about chips or fragments or just the term fractures, and most of the time, I think colloquial terminology will indicate that if you're talking about chips, a lot of times you're talking about ankle chips, which oftentimes be the ones on dorsal P1. And they're often the types of injuries that we see with a horse with overloading of the fetlock, where we get hyperextension actually of the joint, and the dorsal proximal aspect of the pastern bone contacts the condyles of the cannon bone, and then we wind up having a weakening at that point at the top of P1 that winds up chipping off. For the majority of horses, those carry a very good prognosis, depending upon their degree, but they're just like anything else. If you've got a 1 centimeter chip fragment versus a 3 centimeter one, they're going to carry a different level of prognosis because the depth of the injury at that location leaves a lot of exposed bone without cartilage covering it. And so now we set up the horse in terms of a larger fragment that's there to wind up having healing that occurs that leads to arthritis. So I get this question a lot around the commercial market for sales yearlings in the thoroughbred industry, where people talk about P1 chip fractures being taken out of yearlings. And a lot of times that's done not just for a cosmetic reason, but because that limits the ability for arthritis to occur in those horses later in life. So it actually probably is better for the horse long term in terms of its future racing career. It's just a question of the degree of which that occurs. And in our race horses, a lot of times it can occur as they have matured, as their bone structure has matured. We also have to keep in mind that concept I talked about earlier about the stage of which those injuries take place, because the younger horse, the juvenile horse, is able to have the capacity for healing a lot greater than the older horse will have. And so the limiting steps then for arthritic changes to occur that limit their range of motion. If you look at most horses, when people go out and talk about flexion exams, these are the kinds of things that they're looking at in those when they've had potential chip fractures or orthopedic injury, because you wanted to take an assessment of that horse's freedom or range of motion and make sure relative to those flexions when you jog a horse off that they will proceed after the first step or two of being sound, because they give us some indication of how the horse has healed those injuries and how they will adapt to the next part of their careers. And so chip fractures or chip fragments that you hear people talk about are most referred to as dorsal P1 chips. But we also see the proximal P1 fractures that occur on the back of the joint that are actually in the area where the sesamoids oftentimes articulate. And sometimes those carry a very good prognosis. Even though people want to go in and do surgery and intervene, many of them heal back very uneventfully. And some of them heal back and don't always look fully healed and never present a problem with the horse. So that becomes a discussion a lot of times you want to have with your veterinarian relative to assessing that horse and somewhat letting the horse tell you what to do. How is the horse handling that? How does the joint look? Do you see significant effusion or swelling? Because those are indications that, and I guess we probably should have said this before, whenever we're looking at any of these kinds of things, where especially the orthopedic ones, and we're looking at the individual joint that's involved, we want to assess the degree of inflammation that's occurring there. And those things are going to be indicated by pain, so obviously lameness, but then swelling, which will be indicative of joint filling that we see. So what has happened there is the horse's body is trying to respond to that inflammation there by diluting it out, and it's making more and more joint fluid in order to create greater lubrication. But that becomes kind of a vicious cycle for the horse, because the more fluid that it makes, the more range of motion that gets limited. And so it becomes a cascading effect against them. And when they get that much tension on any individual joint fluid begins to deteriorate in quality. It becomes less viscous, less lubricating, and more watery. This is why people want to intervene in terms of tapping those joints and letting some of that pressure off of them and replacing them with hyaluronic acid, because that's the normal component of joints. And so it is in the best interest of the horse in a lot of those situations to replace that damaged joint fluid with the components of what is supposed to be there to allow them to heal effectively. And so you hear people think about those things in a deleterious manner, but sometimes they are very therapeutic in terms of interventional strategies. And so we want to look at all of those things relative to the nature of the injury and how the horse is handling the healing process.
Awesome. I mean, kind of the same approach as we did with the last injury. Can you guys talk a little bit through some of the horses that you've had through your program that have had various degrees of chips, how you decide what intervention to do, if any, and your process to bringing them into work and up for adoption?
Some of ours, go to surgery and then we rehab them from that. Sometimes they get like Prostride injected. Basically, we just let, our vets or our panel of vets consult each other and tell us what direction to go for the best outcome for the horse. And we do take, as Bev said, temperament into account. And certainly a horse that's super hot, that's maybe going to have a limited career, kind of look at that and decide maybe something a little bit more conservative, but one that has, chances of a great outcome. They go on and do all the time they take to get better. And we've been bringing horses in from Puerto Rico lately and rehabbing them. And they come with numerous challenges. But those horses have all been super rewarding to work with, and to help into a new career, even with all the things that they have. And like I said, just following what the vets say to bring them along, and then monitoring it and making sure that they stay comfortable.
We're lucky to work with Maryland because they'll send us horses and they've already done the vet work. If it needs surgery, it gets the surgery. So that's really been helpful. The horses that we work with at Delaware Park, it's a totally different ball game. The one thing I'll say is when I get a horse from Delaware Park that wants to come into our program, I'll get the x-rays from the vet, and then I typically send them to our rescue vet who's at Fairhill Training Center, great guy. I send them to my track vet, and I send them to Patty Hogan. And I swear to God, I'll get 3 different answers from 3 different vets. One will say surgery, one will say rest, one will say whatever. So it's always interesting, and I don't always tell each vet I never tell each vet what the other person said. And it's night and day. So it's really an interesting situation. I mean, I try to, if we think the case is surgical, if Dr. Hogan says no, we go with it. You know, even though the other 2 vets say, oh my God, it needs a screw or it needs a chip removed. So I feel like she's the surgeon. But again, it's amazing the range of opinions I get from the different vets. So
I've struggled with the chips, I think, more than anything. And sometimes we won't know there's a chip, and then someone goes to vet the horse and they find a chip. And I think, like Stuart's saying, there's a lack of understanding. So sometimes they hear chip and panic, and the horse has been sound. There's not been any reason to think it has anything wrong. And so I've had a couple horses. I had one that was wonderful, and we ended up, I'm really lucky with Canter, he could go to Canter, Michigan, and the vet school there can do whatever they decide to do. So a lot of these horses end up going there and they decide, and so they'll remove a chip, or there'll be a chip that's been removed, but there's like arthritis in there, like it didn't, I don't know if it wasn't properly done, and that ends up being a concern. But the chips have been a big problem with them coming off the track, and I guess a lot of times we don't get x-rays beforehand to see, so it's kind of.
And I think you bring up a good point, and relative to what Bev and Lori are saying too. Some of it, the success related to your recommendations and prognoses for these, so back to the variant opinion, have a lot to do with what your experiences have been. And it's case selection a lot of times. And some of that has to do with the temperament of the patient. So you can do the most pristine chip removal surgery, but then have a horse that in post-op care is a terrible stall walker or a weaver, or won't tolerate bandaging, or all these other things that can go into it. And ultimately, the success of your investment in the surgical time is predicated upon how well the horse is able to tolerate the post-operative period. And so that also has a bit to do with what we look at in terms of outcomes. And so, yes, I think sometimes we also see in those cases that there may be some, remodeling changes that occur following the surgery. We hope that those changes are actually better than our original dilemma, but that gets back to the point of assessing the condition of the patient first in terms of the suitability or the need to do the interventional surgery in the first place. Because many of those things are never bothering them, as you point out.
For Bev and Ashley and Lori, have you seen an evolution of the level of knowledge of your adopters when it comes to injuries and having a realistic idea of what the prognosis and long-term will be? Or are you seeing something different, or even the opposite, of people becoming more hypersensitive to injuries in the not perfect horse?
I'll just say, if you go on Facebook, you will find everybody who knows everything.
Everyone's a vet.
I mean, it's just like unbelievable. We posted a horse with knee chips, said he's suitable for dressage or trail, and some guy came on. We don't want any of those weak ring riding horses. We ride 8 and 10 miles up a mountain and back. And I felt like saying, you know what? Man from Snowy River, see ya. Anyway.
I think most of our adopters tend to not get people that have owned horses before, and they're pretty realistic about what they want and what they're gonna do. And that makes it a little bit easier to point them in a direction to adopt a horse with the right temperament, and the right suitability for what they wanna do. So they tend to, follow that recommendation after we've had numerous conversations about all of it. And then our vet will talk to their vet and look at all the records. And I think them not being first time horse owners helps a lot.
We'll get her question after you.
I just don't know that people are always realistic with their abilities and goals and what they're going to do for the horse that they need. It just doesn't always match, or they want a horse to do a real low level job. But like I was saying earlier, there's one little thing that might keep it from doing some other job that doesn't have anything to do with the job they want it to do, and they panic about it. So I just don't know if there's a realistic view sometimes.
Well, and to piggyback off of what you're saying, how do you navigate that fine line of trying to educate them enough to be realistic about what they need and what the horse is, but not overstep your bounds and be coaching them where their trainer should be, and not stepping on, hopefully they have a trainer, not stepping on their toes?
The one thing I'll say is that I find that our farm vet, who's really a good vet, even though he might have different opinions from the surgeon and the track vet, he's really good at talking people through, like, okay, what do you want to do? This is what I feel. And if he says, I really don't think the horse will work for you, we're fine with that. We've had other vets who aren't familiar with thoroughbreds or racehorses come in to vet a horse, and we had a horse turned down because she towed in, yet the lady just wants to trail ride for the rest of her life. But because this filly towed in, she'll never hold up for her trail riding. And we're not talking Man from Snowy River, we're talking, riding on the beach or whatever. So I think that the vets play an important part in educating their clients.
All right, and we've got a question here from
Is
Jess.
this on?
It
It's
is.
actually not a question. I just wanted to make a comment. So I run the program Beyond the Wire in Maryland, and we're a transition program. So I'm based at the racetrack, and I transition race horses to program. Like, actually, Bev is one of our big facilities. We work with a number of different facilities, but 2 points I wanted to make about what you guys are talking about. One is that I think that people that are in the position that Bev is in, and you all running your facilities, actually play a good role in educating people about these injuries, because you find a lot of people that aren't familiar with injuries that are common at the racetrack. We're so used to dealing with them. And I think if you find a good way to explain them, that they're not as scary as they sound, I think that these facilities themselves have educated a lot of people. You were asking if people are getting more or less educated. I don't envy them having to deal with adopters at all. I'm glad I don't have that part of it, because I know there's people, I think that you were kind of alluding to, that are difficult and have unrealistic expectations. But I think the facilities do a really good job educating people, and I think there's a role for them to do that. I think the other thing is Bev does a great job of this, and I have another facility that does as well. They disclose the injuries, and they give full information on it. And one of our facilities actually kept statistics on that. They get less calls about those horses, but higher yield calls. So they may not get the 10 calls that they get for other horses. They may get 3, but those 3 are more likely to actually be adopters. So I think there is value in, in giving that information out, because it's going to come out eventually anyway, and you're going to waste your time, I feel like, not giving it all up front. So just wanted to mention that.
Those are great points. Thank you. We also wanted to talk about soft tissue injuries. I know you guys deal with a ton of soft tissue injuries, which are equally, if not more so, time consuming and a lot of times challenging. So Stuart, can you walk us through kind of the overview of soft tissue and some of the high points injury wise that most people are probably dealing with?
Yeah, I think the one just 50,000 foot comment about soft tissue injuries, if we're talking about tendon and ligament injuries for the racehorse, that's rate limiting in terms of their career is that you can do a lot of therapies and a lot of interventional approaches to improve the capacity for those horses to heal. But oftentimes what most horsemen will relate or trainers will relate to you that happens to them is that through diagnostic ultrasound to track healing and the progress that those horses will go through in terms of completing the healing process, is that they often get those horses through their 3 furlong and half-mile works and get up to their 5 furlong works as they're getting ready to be a 1 or 2 works away from a race, and they'll have the repeated failure of that potential ligament or tendon that they've had previously because the horse didn't hold up. And that's a very common experience that I think a lot of people have relative to bringing those horses back. And it's indicative of the fact that the healing process is never as good as the original structure was. And if we think about the alignment of ligaments and tendons in a longitudinal plane where fibers are connected, they're like little bundles that have tensile strength because they're aligned appropriately. And when they tear, they oftentimes heal with cross-linkage, and we get a fibrous connective tissue scar. And so we lose, when it comes to tendons, keep in mind the tendons, by virtue of their definition, are suspended in a synovial structure. So there's a sheath around a tendon, and so they move up and down in that sheath like a piston. And so there's lubrication in those. And when we get injuries in those locations and there's healing, a lot of times that collateral healing they have around, they're outside of their normal orientation leads to the lack of the ability for the tendon to now slide up and down in the sheath. So we get adhesions that form there, and a lot of times they tear when the horse comes back into work, and so then it winds up being another rate limiting step in terms of the horse's capability to get back to its intended use. When it comes to suspensory ligaments or distal sesamoiding ligaments, things of those nature that are connective tissue structures that support the suspensory apparatus, a lot of times we wind up with fibrous connective tissue scars that replace the normal structures. And while on ultrasound they look like they're healed completely and they filled in the void of core lesions we talk about, which are actually the holes we see on ultrasound when there's an inconsistency in terms of the tissue structure that we're ultrasounding. Many times they will fill in, but they fill in with tissue that's not like the native tissue that formed the original structure. And so they don't have the elasticity and the springiness that those original structures did. And so when they reach high tensile strength, when they're put under a load, they fail and they re-tear again and they have to re-heal all over. And each time they do the subsequent injury and there's more tearing and more healing and more tearing and more healing, we get less and less compliance of the tissue to be able to handle the load that the horse must sustain for performance. And so they become an issue relative to the horse getting back to its intended class in terms of competition. So you hear people talk about, well, you could probably rehab this horse effectively, but if it was a stakes horse, it might now be an allowance horse. Or if it was an allowance horse, it might be a claiming horse. Or if it was a high-level claiming horse, it might certainly now be a lower-level claiming horse in order to perform at the level that they're successful in competition. And so in a lot of racehorse owner minds, it may be that that's not suitable for them to make that commitment to, or they think that the horse deserves to go into another direction in terms of a career, much like we may find for a lot of our thoroughbreds, and they may be completely successful in those other careers because they can handle the strength and the load that's going to be put on those structures now in a different career outside of flat racing.
Now with the soft tissue injuries, there's so many different, like you alluded to, the therapies that you guys can use. Do you utilize a lot of those therapies, or is your goal to try to get the horse into a situation that someone else would utilize those therapies to continue the rehab after they adopt the horse?
That me or?
Excuse me, not for you, for the ladies on the panel.
I'm spoiled. Most of the ones with soft tissue injuries, if they're going to take a while to rehab, they usually go to Canter, Michigan, instead of staying with me. I have my own horses in my program. I've had to do soft tissue injuries, but the Canter horses tend to go somewhere else. I'm spoiled.
For the time or for therapy work as well?
Yeah, our horses, so we have rehab fosters that take care of that stuff for me before I see them, where they come into training. So then when they come to me, it's just kind of monitoring it and slowly introducing them to work in a gradual and systematic, sensible way so that they can stay sound, and gradually increasing the turnout that they get, and the size of the turnout and the herd they go out with, all those things so that we maintain what they gained when they were being rehabbed. And we tend to not end up having problems again, just because we go about it very, very slowly, and try to be super thorough and not push them. You know, realistically, they're changing careers and being rehabbed from something else. What's the rush? It's not like, you know, we're really pushing them to get to that big show next week or what, you know, so they get what they need.
We typically don't place a horse out until it's totally finished its rehab. We tend to be a little less, I know there are all these therapies for tendons. We tend to just give them time, Dr. Green. I know that, you know, there's some people who believe stall rest for a tendon. I like to get them moving even in a small situation. We have our one rehab farm has a great setup where they have a stall attached to like a 20 by 20 paddock. So the horse has sort of a large stall that they can actually move around and walk. And I just feel as though they heal a little better. They don't get as frozen, or, you know, the adhesions don't set up quite as much. We have a horse that's competing here who was from Delaware Park, and he had a bad bow to the point they were going to put him down. I mean, it was the biggest bow you've ever seen. And we gave him the time. He had a year off after he came to us. And now you can't even see the tendon. You can feel it, but you can't see it. And it was one of the biggest bows I've seen. And, you know, so we rehabbed him, we gave him a year, and then they adopted him and they started him slowly and built. And he's showing in the jumpers. And I think, as Stuart said, you know, he's not going to go back to racing. So I think we're good there. You know, I don't know that I'd ever want him to go, not that he would, but the strain is so different when you're even, you know, doing jumpers as opposed to running at the racetrack.
Mm-hmm.
You know, Bev brings up a really good point, and so does Lori, about the discipline with which you bring horses back from soft tissue injuries. And it helps you to calibrate their progress in healing so that you can intervene quickly if they can't handle something, to give them more time and add to the ability for the horse to heal. So if you turn on TVG or any of the broadcasts of the Keeneland race meet for the rest of this month, you'll see Robin Reisenbeck, who is a female outrider that I work with at Keeneland, and she has this lovely horse named Money. He's a bay with a white face who bowed both front tendons, and he was trained by Steve Casey, who's the official clocker at the Thoroughbred Center here during his career. He's a very successful racehorse. Bowed, had just the type of injury you're talking about. Robin did a wonderful job because she was, you know, had an affinity for this horse, had a connection with this horse, and he's 16 now and is a phenomenal outrider horse. He loves his job. I mean, you can watch him every morning, how his ears are always working and how he's watching and listening and the things that he does on race day. I'm always so impressed with that horse because he was a horse that people thought about at the time it was bowed so badly he couldn't do anything. And he loves his vocation and he loves to be a trail horse for her when we're outside of the race meet. But he stayed extremely sound, and he's a great success story and all the things that he gets to do. And there are tons of people that come by to see Money all the time at the racing office because they remember Money and they remember his career, and then they see all these things that he gets to do. And he's such a happy horse, and he's such a sound horse, and he defies those, at least, you know, in terms of the anecdotal claims of others that they won't be able to heal or they won't have a usefulness.
All right, before we wrap up, I will ask, does anybody have any questions for our panel that they'd like to ask, or specific questions about horses in their care or in general with their program? Can I ask you to say it in the microphone?
For Dr. Brown, so we've had a lot of success with tendons in particular in the hunter jumper field, more so than with suspensory injuries. we've kept those as much lower level horses. The adhesions you're talking about. My question is, so we've had a couple horses that have popped an adhesion, and it was sort of like 3 or 4 days acute, and then a significant drop off in a pain level. So my question for you would be, are your experiences with those similar, where not to like the panic level that we talk about? And I try to get my clients, don't panic about the adhesions quite
Right.
so much, because, yes, they can be quite acute, and
Right.
actually more so than suspensory or tendon injuries. It's kind of like more of that mild limp.
Yeah. I think
And the
it had-
adhesion can be very, very acute pain.
Yeah, and I think what you described too is relative to the fact that differentiation between the tendon versus ligament and the synovial sheath structure that the tendon exists in, the environment that it's in. When those adhesions give way, there is some acute inflammatory response associated with them, and then the horse handles that right, and then they move on. Sometimes, in a lot of those cases too, you've even seen them with some of the interventional therapies. So, for instance, if you do PRP or a stem cell and those kinds of things to help them with effective healing, sometimes even the intervention could leave the potential for a flare that exists there that leads to a potential adhesion formation, and then the horse deals with that and then moves on. And it has been effective healing, but it's a part of the process for the horse to recover from that and then to kind of move on. And so, yeah, I think that's a really good point. Not to quote unquote panic at the first sign of that, but to calibrate that a little bit in supporting the horse, and then see if they can't deal with it and move forward.
And then just a comment, we had a knee chip. He's now 10 going 11. He was treated, I think it was root and riddle, don't quote me. They did stem cell, and he recovered quite nicely. He's 10, 11 years old. He jumps anywhere from 1 meter to 1.20 meters. We've injected that knee with HA 1 time so far.
A lot of those
and that
horses-
was considered a significant
Yeah.
chip, I guess, not
Yeah.
like
Yeah.
an insignificant one. And he's had a great jumper.
Yeah, and I
he's
think-
was a hot one too. So
Yeah.
we were real careful, with layup and such.
And we didn't get into this, and we could, and you know what, this is a great topic because we could sit here all day and talk about lots of different things and all of our experiences and take lots of questions related. But when we also get into the knee thing, kind of like we were talking about sesamoid fractures, the places where they occur are also really important. So we see a lot of radial carpal chips, or we see distal radius, because they're high degrees of areas of interest because of the range of motion and the load that they take. And they're the areas that we really focus on a lot when we look at 2-year-olds. We also do a lot of stuff with skylines on those horses, where we take those tangential views over the front of the joint and look at the surfaces of a lot of those joints in the various rows, because the upper part of the joint has lots of motion in it and the lower part has very limited, similar to that in the hock. And so, but when the horse carries 65% of its body mass over the forelimbs, obviously the occurrence of knee fractures or fragments that we see becomes that rate limiting step. And so we look at these areas within the joint itself that are areas of high degree of interest. And so we see horses that progress to the degree of failure where they have an actual slab fracture. And sometimes those require a screw to be put in for them to heal effectively. And again, it's back to the magnitude of the injury in terms of what the appropriate management approach should be in the interventional strategy for them.
All right, that was awesome. Thank you for saying that. So we are going to conclude that panel on that note, or this panel on that note. I want to thank our panelists. If anybody wants to get in touch with any of our panelists, we can definitely get you their contact information if you want to discuss certain cases or challenges that you're dealing with from a medical perspective. I will offer Stuart's brain to anyone that needs to use it. And so we're going to get ready for our last panel of the day, which is dealing with challenges that, the aftercare industry is approaching more and more. First, I'm going to pick another name off of my sheet, Bailey Portman. I don't know what organization she's with, but she's going to get the RRP prize. So, pardon? Perfect. Awesome. I will get in touch with her for her prize. Thank you to this panel. Kristen Werner is going to be moderating our last panel, and we'll get that going and get you guys out of here by 4 or so.